Usually when we talk about a medical diagnosis, there is well, I guess a certain expectation of precision. Like it feels kind of like engineering.
Right. Yeah, like it should be exact.
Exactly. You break your arm, you go to the hospital, and the x-ray shows that jagged white line on a black screen. The doctor points to it, and you have this instant visual confirmation. Broken or not broken?
Yeah, we really crave that binary certainty. I mean, it makes medicine feel manageable, like a math equation where everything can be neatly categorized and then treated.
But then you step into the world of chronic skin conditions, specifically the one we are investigating today, and suddenly that x-ray machine is just, well, useless.
Yeah.
The diagnostic landscape transforms into something remarkably murky.
Look, it is the absolute definition of diagnostic muddy waters.
Welcome to this deep dive. Our mission today is to unpack exactly how lichen sclerosus, or LS, is diagnosed definitively. Because it's really not simple. To figure out how doctors navigate this, we are pulling from a massive stack of official gold standard medical guidelines.
Yeah, we've got a lot of heavy hitters here.
Right. We are referencing the British Association of Dermatologists, the European Guidelines, the Mayo Clinic, the British Society for the Study of Vulval Disease, and we're layering in some crucial real-world insights from patient support networks.
And synthesizing all those sources, it reveals a rather frustrating reality. I mean, lichen sclerosus is incredibly common, yet it is notoriously, almost systematically misdiagnosed.
Wait, systematically misdiagnosed? How does that happen with something so common?
Well, a patient will present with the primary symptom, which is this intense, severe itch. And because of that symptom alone, they're routinely brushed off as just having, a stubborn yeast infection.
Yeah.
Or they're told it's just a natural symptom of menopause.
Wow. Which means patients are left suffering for years, sometimes decades, treating an autoimmune condition with over-the-counter antifungal creams that do absolutely nothing.
Nothing at all, yeah.
And the underlying tissue damage just continues to progress in the background. So knowing how this condition is actually identified is just crucial. If you or someone you care about is navigating chronic skin or genital symptoms, understanding this diagnostic process gives you the vocabulary to advocate for the exact exams and tests you need.
Absolutely. And the journey begins in a place that might actually surprise people who are expecting, like high-tech medicine.
Oh, where do they start?
Before any lab tests are ordered, before anyone looks through a microscope, definitive diagnosis usually begins and quite often ends with just a naked eye in the exam room.
Wait, you're telling me a doctor just looks at it? I mean, we have artificial intelligence, we have rapid genetic sequencing, and the gold standard for diagnosing a chronic tissue-altering disease is just looking really closely. Isn't that incredibly subjective?
I know, it sounds almost archaic when you frame it that way. However, the physical markers of lichen sclerosus, when they are fully developed, are exceptionally distinct.
Really? Like, unmistakable?
Pretty much. The official guidelines dictate that a clinical examination by an experienced doctor is the primary standard for diagnosis. They are hunting for very specific visual changes.
Right, and the texts describe these classic signs using language that feels surprisingly poetic for medical guidelines. Like, they look for porcelain white papules and plaques.
Yeah, the terminology is quite descriptive.
Let's translate that real quick. A papule is essentially a raised, solid bump on the skin, while a plaque is a broader, thickened, flat patch. So together, they create these stark, almost shiny white areas of depigmentation.
Exactly. And alongside that color change, the texture of the skin transforms entirely. Doctors look for areas that appear crinkled, which is universally described in the literature as resembling cigarette paper.
Cigarette paper, wow.
Yeah, that specific texture is the physical manifestation of atrophy, which is the thinning of the upper layers of the skin.
I mean, if the skin is thinning out like rolling paper, it must become incredibly fragile.
Yeah.
Which I guess explains the next marker the guidelines mention, which are ecchymoses.
Right. Those are tiny purple blood blisters, or just localized areas of bruising right under the surface.
Just from the skin being so thin.
Exactly. Because the thin skin loses its protective barrier and its elasticity. Even the slightest friction, from clothing, walking, or scratching that severe itch we mentioned, causes the delicate capillaries underneath to just burst.
Ouch. But the structural changes go far beyond just color and texture, though, right? The anatomy itself actually begins to alter.
It does. Lichen sclerosus is classified as a scarring dermatosis. So over time, the chronic inflammation causes a process called resorption.
Resorption, what does that look like in practice?
The inner lips of the vulva, the labia minora, can actually shrink and be absorbed into the surrounding tissue. It can cause tissues to physically fuse together, frequently burying the clitoris under the clitoral hood.
That sounds incredibly painful and alarming.
It is. Furthermore, the disease tends to manifest in a highly specific pattern. Doctors look for what's called a figure-of-8 distribution. It's this white, inflamed halo that circles the vulva and then extends down around the perianal area.
Okay, so it's like an appraiser identifying a rare classic car just by its distinct silhouette and the shape of its taillights. Like,
Yeah.
you don't necessarily need to open the hood if the exterior is that universally recognizable.
That's a really good way to put it.
But this brings up a massive contradiction for me. If it's so visually distinct with porcelain skin and figure-of-8 patterns, why on earth is it misdiagnosed as thrush for 5 or 10 years?
Well, the disconnect stems from how medical appointments are often conducted. Because the overwhelming, debilitating symptom is itch, primary care providers frequently listen to the verbal complaint and just play statistical odds.
Oh, because a yeast infection is the most common cause of genital itching.
Exactly. They assume it's thrush, they prescribe an antifungal cream, and they end the appointment.
So they never actually look.
They rely entirely on a symptom-based diagnosis. And patient advocacy sources highlight a significant psychological barrier here as well. Doctors, particularly in fast-paced primary care settings, might really hesitate to suggest a full visual genital exam.
Because they don't want to make the patient uncomfortable.
Right, out of fear of seeming intrusive or making things awkward.
But the patient is sitting there in agony. So the doctor's trying to be polite or efficient, and as a direct result, a progressive scarring disease goes entirely unchecked.
Yeah, that's exactly what happens.
For anyone listening right now, the takeaway is so clear. You have to explicitly request a visual examination. You must tell your provider, I need you to look at the tissue.
Absolutely. And you also have the absolute right to request a chaperone in the room to make the environment comfortable. That visual exam is the gatekeeper to proper care.
So true, but even when a trained eye is looking, the clinician has to ensure they aren't being tricked by lookalikes, right?
Oh, definitely. Because the diagnosis relies so heavily on observation, a massive part of the process is the art of exclusion. Doctors have to actively prove what the disease is not.
The medical guidelines are stringent about ruling out specific mimics, and the most prominent one I saw in the sources is lichen planus, or LP. They sound incredibly similar, both being inflammatory skin conditions, but there is a massive anatomical differentiator.
Yes, there is. Lichen planus almost universally involves the non-keratinized mucosal surfaces.
Okay, let's put that in plain English. Mucosal surfaces are what? The moist internal linings of the body, like the inside of the mouth or the internal vaginal canal.
Spot on.
And lichen sclerosus behaves differently regarding those tissues.
Radically differently. Lichen sclerosus typically spares the vagina completely.
Yeah.
It ravages the outer skin, the vulva, and the perianal area, but it stops abruptly at the vaginal introitus, which is the actual opening to the birth canal.
That is so weird, it just stops.
It does not cross over into the internal mucosal tissue. So if a clinician uses a speculum and sees internal vaginal inflammation, or if the patient has painful, fleecy white lesions on the inside of their cheeks and their mouth, that strongly points away from LS and toward lichen planus.
That is a fascinating biological boundary. The immune system is targeting a specific type of external skin cell, but just completely ignoring the internal ones. What about other common conditions, though, like psoriasis? Can that mimic LS?
Psoriasis absolutely presents in the genital area, yes.
Yeah.
But the visual signature is different. Psoriasis lesions are typically bright red with a glazed, almost shiny appearance rather than that porcelain white.
Oh, okay, so the color is a dead giveaway.
Usually, yes. They're also generally much less itchy than LS, and they frequently involve the natal cleft, the deep crease between the buttocks, which LS usually avoids.
I noticed the British guidelines also mandate doing swabs during this visual exam. If this is an autoimmune-linked skin condition, a cotton swab isn't going to somehow capture lichen sclerosus cells for a lab, is it?
No, not at all. Swabs are completely useless for diagnosing the actual condition of lichen sclerosus.
So why do them?
Their purpose is strictly to clear away the noise. A patient with LS has highly compromised, fragile skin, like we talked about. So they are incredibly susceptible to secondary opportunistic infections, like Candida albicans yeast or Staphylococcus aureus bacteria.
Ah, I see. If a secondary staph infection moves into the tiny cuts caused by scratching, it's going to cause massive redness and swelling, which completely masks those classic white plaques underneath.
Exactly. Diagnosing by exclusion is a core tenet of dermatology when symptoms overlap. You clear away the superficial infections with a swab test and targeted antibiotics.
And then you check the internal mucosal tissues to rule out lichen planus.
Right. Analyze the color and anatomical location to rule out psoriasis. And what remains, if the classic signs are present, is a confident clinical diagnosis of lichen sclerosus.
Well, the visual exam and the process of exclusion seem robust for textbook cases. But the reality of medicine is rarely textbook.
Very true.
So what happens when the picture is blurry? Or when a doctor suspects something far more dangerous is hiding in that tissue? I guess that's when the process moves from the exam table to the surgical tray.
It is. While a visual diagnosis is ideal, taking a physical piece of sensitive tissue isn't always practical or necessary. Pediatric cases being a prime example where doctors obviously want to avoid trauma.
Sure, that makes sense.
However, a biopsy remains the definitive, absolute gold standard to confirm LS.
But the guidelines don't suggest handing out biopsies lightly, do they? They lay out a very strict set of mandatory criteria indicating exactly when a doctor must cut into the tissue.
They do. The first trigger is diagnostic uncertainty or an atypical presentation.
Meaning it just doesn't look like the classic figure of 8.
Right. If the visual signs are ambiguous, or if the LS is extragenital, meaning it appears on the torso, the breasts, or the back, it can closely mimic a condition called morphea.
Morphea.
Yeah, it's a localized form of scleroderma that also causes hardened, discolored patches of skin.
Huh.
Additionally, if the doctor spots any dark, pigmented areas within the white plaques, an immediate biopsy is required to rule out melanoma.
Wow, okay. And the second mandatory trigger involves treatment failure, right? The first-line defense against LS is an ultra-potent topical steroid, typically cloberazole propionate.
That's the one.
So if a patient applies that diligently for several months and the tissue architecture just continues to degrade, the guidelines mandate a biopsy to figure out if the initial clinical diagnosis was wrong.
Exactly. And this creates a fascinating divergence in how guidelines are applied depending on the patient sitting in the room.
How so?
Well, for an older postmenopausal patient presenting with unmistakable classic visual signs, prescribing the ultrapotent steroid first and seeing if it works is standard accepted practice. The visual evidence carries enough weight.
Right. But if you are a young adult female in your 20s or 30s, the rules change completely.
They do. Lichen sclerosus is statistically less common in that younger demographic. A positive diagnosis means committing that young patient to decades of lifelong, heavy-duty steroid application just to prevent anatomical scarring.
So because the stakes of the treatment are so high and the duration is so long, guidelines heavily encourage performing a biopsy right away on younger patients to secure absolute definitive proof before starting the regimen.
Precisely. You want to be 100% certain before altering someone's daily medical routine for the rest of their life.
That makes total sense. Now, there is one final critical reason a biopsy is non-negotiable, and it seems like the one that carries the absolute highest stakes.
Yes. A biopsy is mandatory if there is any suspicion whatsoever of neoplastic change.
Neoplasia. That refers to new, abnormal, and uncontrolled cellular growth, right? We are talking about the precursors to cancer.
Specifically, vulval intraepithelial neoplasia, known as VIN, or outright squamous cell carcinoma.
What are the visual red flags that scream cancer risk and demand an urgent biopsy?
Clinicians look for any persistent ulcer or open sore that simply refuses to heal, even with steroid treatment. They look for new, unexplained lumps, thickened warty growths, or areas of fixed erythema.
Fixed erythema being, what, a stubborn, localized redness that just doesn't fade?
Yes. The baseline risk of a patient with long-standing, unmanaged LS developing squamous cell carcinoma is statistically small, usually cited around 3 to 5%. But the risk is incredibly real. A biopsy is the only tool capable of revealing what is happening at a cellular level.
So the mechanics of the biopsy itself are crucial then. The procedure is an outpatient process, utilizing local anesthetic to numb the area. But the specific surgical technique used is a make-or-break factor according to the pathology guidelines.
Oh, absolutely. The doctor must perform a punch biopsy. They cannot, under any circumstances, perform a shave biopsy.
Let's break that down. That distinction is paramount because lichen sclerosus is a skin-deep condition,
Yeah.
but we mean that in a literal structural sense, right?
Yes. The disease process affects the entire vertical column of the skin. So you have the top layer, which is the epidermis, the thick middle layer, the dermis, and sometimes even the deeper hypodermis.
And a shave biopsy.
A shave biopsy involves the doctor taking a surgical blade and essentially just skimming off the very top layer of surface cells.
It's like taking an ice core sample in Antarctica. If a climate scientist wants to see a million years of atmospheric history, they have to drill a deep vertical cylinder all the way down through the ice shelf.
I love that analogy.
Right, because if they just scrape up a handful of loose snow from the surface, they learn absolutely nothing about the foundational layers.
Okay.
A shave biopsy just scrapes the snow.
Exactly. If a lab pathologist only receives a superficial shave sample, they are completely blind to the depth of the inflammation or the structural changes happening in the dermis below. They will almost certainly return an inconclusive, frustrating result.
Because they can't see the whole picture.
Right. A punch biopsy utilizes a specialized circular blade, usually about 3 to 4 millimeters in diameter, to extract a full-thickness vertical cylinder of tissue. The pathologist gets the entire ice core.
Okay, so once the lab tech has that full thickness cylinder, they slice it, dye it, and put it under the microscope. And the textbooks outline a very specific cascading sequence of cellular damage they are hunting for.
They do. The first marker is irregular saw-toothed acanthosis.
Acanthosis.
Yeah.
That's a medical term for an abnormal thickening of the skin layers, right?
Yes, in classic LS, the usually smooth boundary line between the upper epidermis and the deeper dermis becomes jagged and irregular, really resembling the teeth of a saw.
Wow. And the second marker explains the fragility of the skin, I assume. Basal cell liquefaction?
Yeah, that's exactly it. The basal layer is the very bottom foundation of the epidermis. In lichen sclerosus, the body's autoimmune system dispatches T cells that mistakenly identify this foundational layer as a foreign threat.
So they attack it.
They attack it relentlessly until the basal cells quite literally break down, lose their structural integrity, and liquefy.
I mean, if the foundation of the skin is turning to liquid, no wonder the capillaries burst so easily.
Exactly. And then, moving deeper into the dermis, the pathologist looks for subepidermal hyalinization.
Hyalinization. What is happening there?
It's a process where the collagen, the structural protein that gives skin its stretch and bounce, becomes homogenized. It degrades into this pale, glassy, stiff, almost scar-like sheet.
Oh, wow. If the collagen is turning into a stiff, glassy sheet, that perfectly explains the cigarette paper texture we talked about earlier and why the tissue loses all its elasticity and tears.
That is the exact mechanical cause of the visible atrophy, yes.
Yeah.
And finally, beneath that glassy layer of ruined collagen, the pathologist looks for a dense band-like infiltrate of lymphocytes.
Lymphocytes being white blood cells.
Right. Seeing a massive swarm of them clustered directly beneath the gamete confirms this is an active, aggressive, inflammatory autoimmune response.
Yeah. Sawtooth thickening, liquefying foundational cells, glassy, stiff collagen, and a swarm of attacking white blood cells. I mean, it sounds incredibly definitive. It sounds like that perfect X-ray we talked about at the start.
It does sound like that.
But the guidelines drop a massive, unexpected plot twist right here. According to the data, only 25% of lichen sclerosus cases actually display these classic markers on a biopsy.
Yeah, that statistic really forces a major paradigm shift. Only 1 out of every 4 biopsies perfectly matches that dramatic textbook sequence of cellular destruction.
Wait, how does that even make sense? If a deep punch biopsy is the ultimate gold standard, how can the results be ambiguous 75% of the time?
It happens because the microscopic features of the disease are highly variable depending on timing.
Timing, like when you catch it?
Exactly. If the biopsy catches the disease in its very early stages, or, and this is common, if the patient has already been partially treating the area with a mild steroid, the cellular damage looks totally generic.
Oh, so the inflammation might just overlap heavily with a dozen other skin conditions.
Right. The biopsy is not a magical truth machine that prints out a binary yes or no.
So if the tissue under the microscope is ambiguous the vast majority of the time, how does anyone ever get an official diagnosis? I mean, you're basically flying blind.
Well, the guidelines emphasize a practice called active clinico-pathological discussion.
Which means the professionals actually have to talk to each other.
Shocking, right? The clinician who examined the living, breathing patient in the room and the pathologist examining the dead cells on the slide, they must collaborate.
So they compare notes.
Yes. The pathologist might look at the slide and say, well, I see some generic inflammation and a bit of thickened skin, but no glassy collagen or liquefaction. It's not classic LS.
And the doctor replies, I understand, but the patient has stark porcelain white plaques, severe architectural resorption, and a textbook figure-of-8 distribution.
Exactly. They merge the visual, macro-level evidence with the micro-level cellular data to reach a consensus. A biopsy read entirely in isolation, without the pathologist knowing the patient's physical symptoms, is a massive liability and frequently leads to misdiagnosis.
Okay, so we've covered the visual exam and we've drilled down into the microscopic tissue layers. But what about systemic testing? Like, when I go to the doctor for a mystery ailment, the very first thing they do is tie off my arm and draw blood. Is there a definitive blood test for lichen sclerosus?
This is a highly common expectation, but the guidelines are unequivocal. There is no blood test that diagnoses lichen sclerosus. You cannot draw a vial of blood, run it through a centrifuge, and find a specific LS marker.
So phlebotomy is entirely useless here,
Not entirely useless, no.
but its role is entirely secondary. Lichen sclerosus is an inflammatory dermatosis, and researchers have found strong evidence linking it to systemic autoimmune factors.
Okay, so it is connected to the wider immune system? Yes. For instance, studies have found that many LS patients produce autoantibodies that actually attack a specific protein called extracellular matrix protein 1.
Extracellular matrix protein 1. So think of that as the biological glue holding the deeper skin structures together.
That's a great way to picture it.
If your immune system is generating antibodies to attack your own biological glue, your skin is going to literally fall apart.
Precisely. And because we know the immune system is misfiring in this way, doctors understand that LS rarely operates in a total vacuum. Female patients with LS have a statistically higher frequency of developing other autoimmune disorders.
So while a doctor can't find LS in the blood, they will order blood panels to look for associated comorbid conditions.
Right.
If the immune system is already attacking the skin, I imagine doctors start looking at other common autoimmune targets like the thyroid.
Thyroid function tests are incredibly common, as autoimmune thyroid disease often runs in tandem with LS. They might also check ferritin and B12 levels to screen for pernicious anemia or run tests for vitiligo or diabetes.
That makes a lot of sense.
However, the guidelines include a massive caveat. These systemic investigations are only recommended if they are clinically indicated by the patient's broader health.
Meaning they only test your thyroid if you are actually reporting symptoms of a thyroid issue, like chronic fatigue, hair loss, or unexplained weight changes.
Exactly. They don't just run a $10,000 autoimmune blood panel on every single person who walks in with an itchy patch of skin.
Blanket testing is discouraged.
Yes, the goal is targeted investigation based on the holistic presentation of the individual. And the same restraint applies to patch testing, actually.
Patch testing for allergies.
Right. Occasionally, a patient will report that their LS seems to burn or worsen when they apply their prescribed steroid ointment.
Are they allergic to the steroid itself?
They might be, or they might be reacting to the chemical preservatives within the cream base. In those specific rare cases, a doctor might order a patch test on the patient's back.
Oh, I get it. But they aren't testing to see if the patient is allergic to lichen sclerosus.
No, they are testing to see if the patient has developed a secondary contact allergy to the very medication trying to heal them.
So to summarize the blood and allergy stuff, you don't get a blood test to find the disease. You get a blood test to see what other autoimmune uninvited guests the disease might have brought along with it to the party.
I love that. Yes, treating the entire human being rather than developing tunnel vision on a localized patch of skin is really the hallmark of expert, comprehensive dermatological care. You aggressively manage the localized LS, but you remain vigilant about the patient's overarching immune health.
Mapping out this diagnostic journey really reveals a path that is just anything but a straight, clean line. It begins fundamentally with human observation, right? A clinician who knows how to spot the porcelain depigmentation, the fragile cigarette paper texture, and the architectural scarring.
It does. And it requires a rigorous, methodical process of exclusion, proving the symptoms aren't caused by mucosal lichen planus, or bright red psoriasis, or secondary bacterial infections.
And when the visual evidence isn't enough, or when high-stakes steroid treatments fail, or when there is a terrifying suspicion of cellular precancer, the process shifts to the deep punch biopsy as the ultimate arbiter.
But even then, as we saw, the clinician and the pathologist must bridge the gap between what the eye sees and what the microscope reveals.
Because only 25% are clear-cut textbook cases.
Exactly. The true value of this deep dive, I think, is empowerment. If you or a loved one are trapped in a cycle of severe, unyielding itch and pain, you now understand the mechanics of a proper diagnosis.
Yeah, you know to reject a rushed 5-minute assumption of a yeast infection. You know to demand a visual exam, and you know to insist on a full-thickness punch biopsy rather than a superficial shave if tissue actually needs to be taken.
That knowledge is your armor.
Absolutely. Well, I want to leave you with a provocative thought to mull over. We began by comparing medicine to the flawless binary precision of an X-ray. But if a disease as prevalent as lichen sclerosus is diagnosed primarily by the human eye, and the definitive gold standard biopsy only shows classic, unmistakable markers 25% of the time, well, how much of modern medicine still relies on human intuition, nuanced pattern recognition, and subjective interpretation rather than purely objective lab data?
That's a heavy question.
It really makes you wonder how many conditions we view as hard, infallible science are actually closer to a highly educated art form. Something to think about.